Parkinson's disease. I am going to touch a little bit about some of the other movement disorders that cause tremor and shakiness. It's a very broad topic, and there's a lot we could cover. I could talk all day about it. So in an effort to try to focus things today, we're mainly covering Parkinson's disease, but I'll try to touch on some of the other things. And if there's any questions that come up, you can ask at the end of the session. So Parkinson's disease is one of the more common types of tremor that we see in clinic. It affects 1% of people over the age of 60, so it's actually quite common. It does affect men more than women, and again, usually affects people later in life, but there are some people that do develop the disease younger in life, in 20s, 30s, or 40s. We know that it's usually a slowly progressive disease. It's one that people generally live with for years, sometimes even decades. We don't know what causes it specifically, although we have a lot of insights into factors that seem to increase risk for Parkinson's. There's a lot of genetic susceptibility. There are genes that by themselves cause Parkinson's, but also genes that just increase your likelihood of getting Parkinson's. Doesn't mean you will absolutely get it, but it increases your risk. There's also probably a lot of environmental exposures, and it's probably more than one exposure. These are some of the things on the list that we know of: manganese exposure from welding, use of certain medications, and pesticides. Again, a lot of people are exposed to those and don't develop Parkinson's, so there's other things required. It's not that one exposure is going to give you Parkinson's disease. Interestingly enough, smoking seems to be protective. This is probably the only medical problem I know of where smoking may protect you from the disease, and we don't know why that is. But don't go smoke just because of that. So the two main things that happen in Parkinson's, one are loss of neurons, nerve cells that produce a chemical called dopamine, and these are located in a deep part of the brain. If I could get the point, oops, nope. Let's see. Maybe the pointer works. Okay. These dopamine-producing neurons are deep in the brain. The other thing we see happen in Parkinson's is the formation of Lewy bodies, and basically these are misfolded proteins that accumulate in cells and basically cause some cells to die. This is a common thing that happens in all neurodegenerative diseases. Those are diseases that cause degenerative changes in the brain over time, like seem to stem from some type of protein misfolding and cell death that happens over time. With Parkinson's, what we understand is that really the alpha-synuclein, these proteins that misfold, start outside of that deep area in the brain called the substantia nigra, where the dopamine neurons live. And one hypothesis right now proposes that Parkinson's actually starts in the olfactory bulb, which is the part of the brain that controls sense of smell right above the nose, or in the gastrointestinal system. So completely different than the brain, but similar neurons that live there. And so that this is something that spreads over time. And this is kind of an example of showing how alpha-synuclein starts spreading throughout different parts of the nervous system and eventually ends up causing a lot of different symptoms. It's not just tremor in Parkinson's disease, it's a lot of different symptoms. So really, as the neurologist, when I see people coming to clinic because of trouble walking, balance problems, stiffness, tremor, we're really seeing kind of the later stage, actually, of a disease that probably started several decades before. What we know in Parkinson's is most people with classic Parkinson's disease usually have prodrome symptoms for several decades, and these might be constipation, depression. Those are very common symptoms in general, so hard to know. Loss of sense of smell, which happens earlier in life. And then probably the most specific one for Parkinson's disease, because as I mentioned, lots of people have depression, constipation, and trouble smelling. REM sleep behavior disorder is one that does seem to be more closely connected with later development of Parkinson's. So about 80% of people with that sleep disorder develop Parkinson's later in life. And these are people that routinely multiple nights a week, frequently act out their dreams, punching, kicking. Usually the spouse ends up sleeping in another room because they're attacked during sleep. So it's a very specific sleep disorder. It's not a very common sleep disorder, but it's having that disorder does seem to have a connection with developing Parkinson's later in life, and they're probably coming from the same problems happening in the brain. A lot of people, when they think of Parkinson's, the first thing they think of is tremor. But actually, the key feature, the classic feature in Parkinson's that has to be present for us to make the diagnosis is bradykinesia. And that is a slowness in movements. Movements get really small. The gait changes from a nice, long flowing stride to this short, shuffling gait. The facial expressions diminish. The voice gets quieter and softer and harder to understand. Those are actually the main features that we look for to make a diagnosis of Parkinson's. A lot of things cause tremor, and tremor can be much more difficult to sort out. The Parkinsonian tremor does have some features that makes it different from other types of tremor, like essential tremor, which is, again, probably the most common cause of tremor we see, where people complain of shakiness in the hands and trouble drinking liquids. They notice a tremor when they reach for things. The Parkinson's tremor tends to happen more at rest. People can express it, but it's usually happening at rest. And it kind of looks, we call it a pill rolling tremor. It has this classic movement, almost like somebody's shaking a bottle of pills. Other features of Parkinson's that we see are rigidity. That's a stiffness. It's usually on one side of the body. Whatever side the Parkinson's is starting on. Most neurodegenerative disorders start on one side of the brain. So you usually see on one side that there's stiffness. A lot of times early on it's shoulder pain that's the main complaint. And it can be very hard for doctors to sort out what's going on with the shoulder. A lot of people in their 60s, 70s have rotator cuff problems, arthritis, other issues in the shoulder, and it may not become clear that it's a neurologic problem until other symptoms develop. And then postural instability, poor balance, tripping easily, not able to navigate turns very nimbly is very common in Parkinson's and gets worse as the disease progresses. If you have Parkinson's or know anyone that has it, you know that the symptoms I just described are only like half the disease. There's a ton of other symptoms that come with Parkinson's. And again, this speaks to the fact that this is a disease involving not just one specific part of the brain, but the whole nervous system and many other bodily functions as well. So commonly we see mood problems, anxiety, depression, sometimes paranoia. We see orthostatic hypotension, which is a problem where when you stand up, you get dizzy and lightheaded and sometimes even pass out. That's because the nerves that control the reflexes to contract our blood vessels and make our heart pump stronger when we stand don't work. And so you stand up and instead your blood is not getting to your brain as quickly as it would like, and you get lightheaded and dizzy. Sleep problems are huge, as is fatigue, for lots of different reasons. Restless leg, again, there's some connection between these movement disorders. So restless leg syndrome is a very common disease where people feel the urge to move their legs at night when they sleep. People with Parkinson's do seem to be more likely to get that disease. Not that restless leg predicts Parkinson's, it's not that way, but some people with Parkinson's do get restless leg symptoms. Parkinson's can affect the gastrointestinal tract, so constipation is almost always a problem. Urinary problems can also be difficult to manage. There can be a lot of chronic pain because of that stiffness that I mentioned, and then sometimes visual disturbances, hallucinations, seeing things that aren't really there. That's, again, part of the brain playing tricks on you because it's not working normally. The diagnosis of Parkinson's can be really difficult it can be hard to make in a lot of patients. If patients have a kind of the classic presentation of Parkinson's, it can be pretty easy and straightforward for most doctors, but we see a lot of people with unusual tremors, variations of tremors. We have people that have essential tremor earlier in life, and then they develop Parkinson's type tremor later in life. And even an experienced neurologist or movement disorder specialist sometimes doesn't know. and has trouble figuring out what's causing somebody's tremor or other symptoms. So generally, we don't have much other than the clinical exam to rely on to make the diagnosis. So sometimes it's a matter of watching over time and seeing if symptoms worsen, if new symptoms develop, or if symptoms get better. We do have access to scans. An MRI scan is usually done if we're trying to figure out what the diagnosis is, and part of that is simply to rule out other things. People can have strokes that sometimes cause Parkinson's symptoms, other types of brain problems. So a lot of the MRI is looking for other causes to explain the symptoms. There is now a dopamine scan. We don't offer this here. It is available in Colorado that can, in some cases, tell the difference between someone with early Parkinson's and somebody with symptoms maybe coming from another cause. There are a lot of limitations right now with this scan. It's not 100% accurate. It's very subjective. It's based on the reader of the scan interpreting things. And very common medications can interfere with the results of the scan. So it has to be interpreted with a grain of salt. It's very useful in specific situations, but it's not something that we recommend to everyone just because it has a lot of limitations in how we can interpret the data. So it can misdiagnose someone, and sometimes we just really don't want to be misdiagnosing people or relying too heavily on a test that's maybe not as perfect as we wish it were. So essential tremor, as I mentioned, is probably the most common thing that we see in clinic. People often develop this tremor, usually age 30s to 50s, and start worrying that because they have a shake in their hand, maybe they have Parkinson's disease. As I mentioned, it usually has pretty specific clinical features that make it different from a Parkinson's tremor, and it doesn't come with those other symptoms like the stiffness, the gait problems, the walking problems. Dystonia is another form of tremor, probably more commonly seen when it affects the head and neck. It causes shaking of the head and neck. When it's in the arms, usually it's task-specific in a lot of cases where people may not notice a tremor until they go to do specific things, like reaching for something, and suddenly the tremor gets very worse, but they might be able to hold out their hand and be okay. Very hard to differentiate dystonic tremor sometimes from other types of tremor. And again, the treatment is different. Dystonia doesn't respond to a lot of medications. It's really hard to treat. So it can be frustrating for the patient. But if somebody is not responding to medications, that's sometimes what the case is it's a form of tremor that just happens to be more difficult to treat. Atypical Parkinson's, so these are diseases of the brain. They're all neurodegenerative diseases. Again, the brain deteriorating over time. Usually some type of protein misfolding involved and cell death involved. These can look very much like Parkinson's, but they don't respond to the typical Parkinson's treatments quite as well. One is called supranuclear palsy. That's usually someone who doesn't so much have a tremor generally, although they can, but usually more trouble with walking, falls really easily. They have a lot of visual. They can have some neck stiffness and kind of stiffness more in the torso than a limb, and different features that differentiate it from Parkinson's. Multiple system atrophy, again, a hard diagnosis to make, but sometimes can be easily made on an MRI scan because it produces distinct changes in the brain, and people can have a Parkinsonian form of that looks just like Parkinson's disease. It just doesn't tend to respond to treatment as well. And then the third one would be Lewy body dementia. And this usually has some Parkinson's features, but more prominent memory difficulties, visual hallucinations, usually very early. People are seeing animals or other people or shadows or things that aren't really there. They're not frightening per se, but kind of bothersome. And that usually happens very early in the disease. They can have a lot of problems with walking and falling as well, sometimes passing out spells, fluctuating consciousness where their memory and wakefulness seems really good one moment, and then the next day they seem like their memory is not working, or they may have like staring spells or spacing out and different things. So again, doesn't tend to respond to the medications that Parkinson's disease does. As I mentioned, there can be other causes for Parkinson-type symptoms. Big one is stroke, or sometimes just people that have vascular disease of the brain. They may never have had a stroke, but they have a lot of vascular changes in the brain. That's what you're seeing here. This is a very common thing we see in clinic. We go to review an MRI with a patient. They're told they have these white matter changes and possible, there's usually a list of possibilities that this could be. And the most common thing that it is usually some vascular damage to the brain. Small blood vessels get injured over time. It's more likely if you have high blood pressure, if you smoke, and you get these changes that happen. And sometimes they don't cause any symptoms other than maybe some memory difficulties later in life. Sometimes they do cause Parkinsonian features and other symptoms. So there's no curative treatments in Parkinson's right now. We're hoping someday that there will be. Right now, we don't really have much to offer. Part of it, just like with Alzheimer's disease and some of these other brain diseases that happen later in life, we see the neurologic disease start later in life. The disease itself is probably starting decades before. So in Parkinson's, if we really want to prevent the disease or treat it, it'd be ideal to try to figure out who has these diseases when they're in their 20s and 30s. Because by the time we see a lot of the neurologic manifestations, the disease has already progressed quite substantially. So generally, our treatments involve medications and sometimes some surgical type procedures. Parkinson's is funny, unlike other diseases where we usually try to get one medication or as few medications as possible. Most people with Parkinson's do better with multiple medications in smaller doses. So rather than being on one medicine for all of the symptoms, usually they end up having to be on little doses of several things. And this can be kind of disturbing for a lot of my patients who generally may have not had any other medical problems in their life. They might have maybe high blood pressure, but maybe nothing else. And so suddenly to go from one or no medications to now the neurologist is saying you need 5 or 6 medicines, it's overwhelming and seems counterintuitive. But people with Parkinson's are very sensitive to medications. Even the medicines that we use for Parkinson's, they can cause nausea, dizziness, lots of side effects. So we have to be very cautious, start low, go slow, and often use little doses of several things in combination to get the best effect. The main ones that we use, there are medicines that we use primarily for early symptoms or tremor. Amantadine is one. We use dopamine agonists. These are medications that help boost existing levels of dopamine. That can be Requip, ropinirole, or pramipexole. Sinemet, which is levodopa, that's dopamine replacement therapy, is generally something that everyone ends up being on at some point unless they're completely unable to tolerate the medicine. There are long-acting versions of it now, and newer therapies are working on different methods of delivering this medication. There are medicines that can modify the Sinemet, make it last longer so that it doesn't wear off so quickly. So that's an option for some patients. And then Dr. Feller will be covering a lot on deep brain stimulation. And there's some other therapies that are sometimes done surgically to help, often with tremor, but sometimes with other symptoms as well. There are some non-pharmacologic treatments that honestly do work very well. One of them is exercise. You'll get to hear about that later. But Parkinson's is one disease that really responds well to physical therapy, exercise, boxing, dancing, things with rhythm are very good in order to teach some cadence and help with the movements in Parkinson's. The tendency is that people kind of freeze up and don't move very well. And so a lot of these types of physical therapies actually help the brain work better despite the disease. And there's a lot of other symptoms that we often need to treat in Parkinson's. So fatigue is the most common non-neurologic symptom that we see. Almost everyone I see with Parkinson's has problems with fatigue and just not feeling well rested, feeling tired all the time. Sometimes it does get to a point where we need medications to help. Depression, constipation, dizziness, those are all also sometimes symptoms that get bad enough to where people need to be on medication or some kind of treatment for them. Every year there are new things coming out. We still don't have a cure, but I think the medications are getting a little bit better over time. A lot of what we've seen recently are modifications of older medications, like a kind of a 3.0 version of an older medicine. But new things that we do have another new medication for the orthostatic hypotension, that drop in the blood pressure when people stand or move around. There's a new medicine for that. There's one that specifically treats visual hallucinations in Parkinson's and Lewy body dementia. That can be a very disturbing symptom for patients. And sometimes with the visual hallucinations, patients get paranoid. They might think, that somebody's trying to rob their house or somebody's in their house. They get scared about things that they perceive as being real that aren't really real. And so that's where sometimes medications can help if the symptoms get really disabling. And Nuplazid is probably the newest one that we have for that. There's a new, I mentioned Azilect or Razagiline, which has been around for a while for kind of early Parkinson's symptoms. For a while we were using it as possibly a medicine that might slow the progression of disease. It's not clear that it actually does that. And there is a newer version of that called sulfonamide. There's also coming out is an ultrasound therapy that might help tremor. And this is more of a surgical type procedure using ultrasound to target an area in the brain, but it's really just specifically for tremor, not for other symptoms. As I mentioned, most people do end up on the Sinemet, the levodopa. In the past, we know that people who are on levodopa for a long time get abnormal movements called dyskinesias. If you're familiar with Michael J. Fox, you notice that he has kind of this twitch and he's always moving around. That's the dyskinesia. It happens with everybody. We assumed that it probably had something to do with the levodopa therapy and that maybe we should just not be putting people on levodopa until later in the disease in hopes that it might stave off those dyskinesias. But a big study came out last year that sort of contraindicated that. It said really what they saw was the patients for whom we withheld the Sinemet for longer ended up having more problems with falls, breaking hips, a lot more complications and medical problems. And that, yes, the dyskinesias happen, but they happen with everybody. So basically, there wasn't really any difference between problems managing dyskinesias later in life and when the Sinemet was started. It was more of an issue of we saw more problems with complications of people not having their symptoms managed adequately because they weren't started on the Sinemet early enough. So we thought that maybe we were helping to prevent dyskinesias, but unfortunately it is something that happens because of the disease course. And it is something that therapies like deep brain stimulation are sometimes more effective at treating than medication. So, amantadine is another medicine, as I mentioned earlier, that we use it for Parkinson's for a lot of different things. It is one medicine that I will use for the dyskinesias, but unfortunately, sometimes it can be hard to treat. Dr. Feller is going to be talking more about these therapies. I wanted to mention that in neurology clinic, often we're the ones making the decision on when to refer someone for deep brain stimulation. And we're trying to bring the discussion up earlier in the disease course. The problem is generally people, as they age, become less ideal surgical candidates, or other things may change that may not make them an optimum candidate for surgery. And the device actually, I have one patient who has the device and is not on any medications. He's been able to manage his symptoms purely with the device. Another patient, sometimes they can get by on very little medication, so it can be a great option for people that have a lot of side effects from the Parkinson's medication, like the dizziness and the nausea. It also does seem to help the non-motor symptoms. So it's not just targeting tremor. This is targeting a lot of different things in Parkinson's. The criteria are that you have to have the classic, we call it the idiopathic form of Parkinson's. It can't be one of these variations. And so that's where, as a neurologist, my role is important in making sure that we have a correct diagnosis, that we're not mistaking the Parkinson's for something else because other things may not respond to those therapies. And we can't put these devices in, as I mentioned, people that have a lot of dementia and certain other medical problems. So there is a lot of evaluation going into who can be a good candidate for this. I think where you see problems is when people put in devices or do surgery on people that aren't good candidates to start with. That's where you run into patients that have problems and complications. In our experience, the more careful you are up front, just like with anything, with back surgery, with you name it, the more careful you are at picking people that are going to do well with surgery, the better they're going to do, and you're not going to have so many complications. So we have an extensive evaluation done on all these patients with psychiatry, a neuropsychologist, PT, occupational therapy, speech therapy. All of those players are involved in making these decisions. So it's a team decision, not one medication, or not one physician or provider making that decision. As I mentioned, we still don't have any way to prevent or slow the progression of the disease. So these are some of the things currently being investigated, everything from caffeine and nicotine to antibody-type medications, anti-cancer drugs, very broad spectrum of things that are being investigated. At present, it seems like the best prevention is actually exercise. And I will say my patients that are more active and do go to regular exercise programs, particularly ones involving a lot of repetitive movements with rhythm, like dancing or boxing, programs that involve a lot of balance training, they do better. They end up, in my experience, I don't seem like I'm advancing medications as often and as frequently for these people, and they do seem to be able to slow the progression of the disease. So there's a lot of neuroplasticity in this. You can train the parts of the brain that are still working to compensate for the parts that aren't, and I just don't think we always emphasize that enough. So I think I have about 5 minutes for questions, if anyone has any specific questions. Let's see. Let me go here first. A dictionary? Yeah, it's hard to explain. I try to use words that maybe are more commonly heard, but it's hard, I understand. Yeah, if you contact the movement disorder, the Parkinson's disease associations or movement disorder associations, they usually do have some educational materials that can, for different, levels of understanding, that might be a little easier to digest. Okay.
When the Parkinson's is probably affecting the urinary tract, bowels, is there medication for that?
There's medications for the symptoms. Yes. Yes.
And are those prescribed from the neurologist or from the gastro?
It depends. For constipation, most of the treatments we recommend are actually over the counter. And so, things like Miralax or Metamucil, increasing fiber in the diet, a lot of those things don't need a prescription, but your neurologist or doctor can help you kind of figure out where to start with those symptoms. And that's usually a lifelong thing. As I mentioned, most people come in having had problems with constipation for a very long time. The urinary symptoms start later. A lot of people who are over the age of 60 have urinary problems for many reasons. Prostate issues, weakness of pelvic muscles, or issues, a myriad of issues. So there's lots of things. And so sometimes we do need a urologist to help sort out what is the neurologic versus the non-neurologic problems. So sometimes we do refer to a urologist in that situation. Otherwise, it kind of depends what type of urinary symptoms as to what kind of treatment we'd recommend. So usually when people start having restless leg symptoms, it's only at night. But there are people that can get it during the day. There are also people that sometimes when they go on dopamine medication that helps the restless leg, it sometimes causes the symptoms to start occurring earlier in the day. So that is a known effect in about 30% of people that go on dopamine medications for restless leg, is they can start having daytime symptoms. Sometimes we just have to give them holidays from that medicine. Sometimes we switch to a different medication. And there are other people that just do have more severe forms of restless leg where they do have it, you know, more times during the day than just at night when they sleep.
What if you don't have it at night? Your legs just tremor on it. Is that restless leg?
It may not be restless leg. It may be something else. Usually restless leg is an urge to move the leg as opposed to a tremor or shaking of a leg. So it could be something else. Yep.
Yeah, you mentioned the sentiment that there were different ones of it. Giving two different kinds. One was a sudden release and the other was an extended release. You know, I've not been able to get in China and
Yes.
extended release, so I'm now getting medication
Yeah.
8 times a day.
Yes. I've heard there's been some issues with getting the extended release. And I don't know exactly what the problem is. No, I don't believe that they are stopping making it, but I think there's some issues with production. I don't know for sure, but I've heard that from other patients. So hopefully that will be fixed. We've had a lot of medication shortages this last year. Part of it was some effects from the hurricanes that damaged manufacturing, and you know, sometimes there's other issues in the whole process of medication development that cause things to be unavailable.
You had spoke about essential tremor being more of the shake of the head.
Yes.
Can the shake of the head be essential tremor also?
It can. So usually with essential tremor, it starts in the hands and works up to the head and neck. And a dystonia tremor starts in the head and neck often. It can start in the hands too, but more commonly, if that's where it started, it might be dystonia. And they can look identical. It can be very hard to tell them apart. Even if you're a specialist in movement disorders and tremor, sometimes you don't know. So.
Answer some more questions.
Okay. More questions. And I'll go back to, I mentioned this slide here that has a lot of the medications on here. And this is kind of a constantly changing thing because there are new medications coming out all the time. But if anyone has questions on some of the more specific medications, because I realize these slides are probably hard to read, the text is a little small. But this is kind of an overview of how we often think about medications or may change things over time. One thing to point out is with Parkinson's, sometimes a medicine that helps early on can cause more side effects later on. So amantadine is one of those. It's really good for tremor in young people with Parkinson's, and it's really good for the dyskinesias, those abnormal movements that people can get. But then later in life, it can cause memory issues, altered mental status, meaning confusion, people not acting right. And sometimes we do end up having to stop that later in life. So it's a constantly changing mix of medications. I think it can be very confusing for patients sometimes because it seems like their medicines are always changing and things might be evolving over time, but it's because the disease responds differently to medications at different stages. So, yep. It's only severe depression, and generally it's because, it's interesting because deep brain stimulation is actually used off-label for treatment of depression, and it's kind of still an experimental treatment. But we do notice when we stimulate, where we're placing the stimulator for Parkinson's, it can worsen depression. And so these are generally, the contraindication is not anyone with depression because a lot of our Parkinson's patients have depression, but what we're looking for is somebody who's been suicidal, who's had really severe bouts of depression. If they've had to, for example, been hospitalized because the depression got so bad, we don't want to put a stimulator in that might make their mood even worse. So usually we consult with a psychiatrist and or a neuropsychologist, sometimes both, to get their input on how they think they would do. Because mild depression, probably fine. It's just we're kind of more worried about those that have had really severe depression in the past. A lot of times we kind of rely on our psychiatry colleagues to comment on their thoughts. Certainly if somebody's doing really well on medication, they can probably have deep brain stimulation. But that's part of why psychiatrists are involved in our decision making and why we have a psychiatrist embedded in our clinic is to help with decisions like that. Mm-hmm. Yeah. Yeah. So Dr. Feller was mentioning some people do get a little bit of we call it manic, but it's that euphoria where people get a really elevated mood. They feel maybe a little too happy, and that can happen with the stimulation as well. And so, again, if somebody's had issues with a manic mood before where they've maybe done some things that were harmful to themselves, we don't want that to worsen with the stimulation. You had a question?
Doctor says exercise is great.
Yes.
Do you recommend them going to the gym or fast walks, long walks?
Yes.
Generally active?
Sure.
What's best?
So it's a little different for every person. The question was about exercise. What should we be doing or what should I be doing? If you are someone who is still quite mobile, not falling, and your balance is pretty good, you probably can do a lot of things on your own. You may be able to take long walks. Walking is always a good, easy, low-impact exercise. Pool therapy can also be really good, and sometimes that's useful to take that element of balance out of the picture. Or if somebody has, other issues that make it hard for them to walk, like arthritis, pool therapy can be really good. If you feel like you need a little more assistance, if you're having trouble with balance, particularly maybe you've had a fall or you've had some near falls at home, it's probably a good time to get somebody to help you a little bit first. So maybe a couple weeks with a physical therapist just to kind of help fine-tune the balance before you start on your own exercise program. Many of the physical therapy clinics in town, if you go to them and complete therapy, they'll let you use their gym, usually for a small monthly fee. So you can continue to exercise there. There's people around in case you were to fall or have an issue. Many of the fitness centers or gyms in town also have classes catering to people with balance problems and neurologic problems. So the YMCA has a NeuroFit class, and they have balance classes every day. And that's a great place to go to get some help if you're worried or a little nervous about doing this on your own. Get some assistance. There's a great boxing program that we're hoping to get here. You'll get to watch a video about it here in a little bit. But it's a boxing program specifically developed for Parkinson's patients. It's available right now in Laramie and in Fort Collins. And I do have patients that drive down to Fort Collins 3 times a week to take it, but it makes a big difference. And it's the only exercise program out there right now that's very specifically dedicated to Parkinson's. But a good physical therapist should be able to help you out with some ideas if you're not sure what to do and how to do it safely. And they can help you set up a home exercise program as well. So I think it's always worth, if you're not somebody who's done a lot of exercise or gym programs in the past, probably getting some advice is helpful just so you don't hurt yourself.
Is there any information on the effects of chemotherapy? A patient that has Parkinson's and then is diagnosed with stage 4 lung cancer.
Yeah, I don't know if I know anything about that, so I'm not sure I can answer that question. Yeah, that's okay. In freezing with the boxing program? So yes, the boxing program is pretty cool. It teaches a lot of movement and cadence with, obviously there's boxing, but they also integrate stepping and moving sideways, moving, kind of teaching your body how to move around better, and it does help quite a bit with freezing, with agility, with balance. Laramie just started their program in October, and the therapists, when we went and visited, said they could already tell a difference in the patients that had started, that they were noticeably more agile and moving better. The full program. Yes. Yes. So they have therapists who come and do it 3 times a week there.
Let me tell you what it's like. I mean, the doctor tells you 2 things, or at least he told me 2 things. Number 1, this disease, there's no cure for it. And number 2, it's degenerative. It gets worse as it goes on. You feel terrible today, and this is the best you're ever going to feel, and nobody can help you. If that doesn't make you feel alone, I don't know what does.
I was in the Air Force for 28 years, so I'm used to being in good physical condition, and I'm not used to having Parkinson's.
My husband was diagnosed 15 years ago with young onset Parkinson's at the age of 36. He read literature that said, you know, you're pretty much going to be disabled in 6 to 10 years. So he just kind of went home and gave up. Six years later, he found Rocksteady through Scott Newman. And that's the day that his life changed.
The idea of boxing as a remedy for Parkinson's is a strange idea to begin with. A friend of mine who's a cop and he's a boxer, and he said, let's just try this because it's what he knew how to do to get me moving. And that's how it started. There's tremendous power that I cannot describe to you when you realize what this does for people.
Boxers have to work on balance, they have to work on hand-eye coordination, speed, optimal strength, focus, and these are all things that people with Parkinson's disease struggle with.
Forward, step!
We're giving them an opportunity to fight back amongst other people that understand what they're going through.
30 seconds left!
We're saying get strong, learn balance, learn how to get yourself up and down. Get down there and play with your grandkids. We don't want people to stop living. We want them to really embrace that they can do things, that they can live.
Come on, baby!
You've heard probably a lot of our boxers say how much more fun is it to tell your grandkids that you're going to boxing than to say you're going to therapy.
Shift! You got it!
People have improvements in their Parkinson's symptoms, maybe not immediately after exercise, but people who adopt an exercise program, they have fewer tremors, less stiffness, improved balance. You're fighting against the disease, you're taking control of your disease. People go from being withdrawn, being isolated and immobile to coming back to life, and I think everyone should have a chance to access that.
I was worse than this, a lot worse than this, 3 years into the disease. Now I'm 15 years into the disease, and I'm doing better than I was back then. Back then I couldn't write my name.
Progression of my disease has slowed down tremendously. This place gives you hope.
Before I came here, I would think I'm the only person in the world with Parkinson's. That's not true. We are now a family. We really are a family. I immediately recognize, first of all, I'm not alone. And that's important.
Any place could do Rocksteady boxing, and so our vision and my hope is that someday when somebody says you have Parkinson's disease, they'll follow it with, there's a gym down the street where you can fight back.
Come on, Bobby, show me something to do!
What did your friends and family say when you tell them that you're boxing?
They laugh. But now, they don't laugh anymore.
We gotta keep moving!
Hi, We still have a few more minutes before we'll get started with Dr. Feller's presentation, but I did have some information about a support group locally if you're interested, and I'll provide a couple of sheets up here. There won't be enough available for you to take this with you, but you could come and look at the information and write it down. So there is a local Parkinson's disease support group. The meetings are open to the public, and they're held on the first Wednesday of each month at the Laramie County Library. And so the next meeting is this coming Wednesday, April 4th. The meetings are held in the Willow Room from 1:30 to 3 p.m. in the afternoon. And again, on these sheets of paper, the support group leader is Sandra, and her phone number, if you have a pen, and again, I'll put this up here, is 307-274-0057. So again, it's open to the public. You'd be welcome if you needed some more information. And just as an FYI, April is Parkinson's Awareness Month. So you may see some more information on TV or around the community about Parkinson's disease because it is Parkinson's Awareness Month. So again, thank you.